Welcome to this video for APS 505. My name is Che and today's video is going to look at patient positioning for patients requiring airway management and airway assessment. First of all, let's take a look at patient positioning. So obviously the indication for patient positioning is any patient that is requiring airway management. The contraindications would include if injury or anatomy prevent the safe application of these positions. Some considerations or modifications would include the patient that is spinally immobilised and that the amount of padding and the position of the padding will vary depending on the position we've chosen and the size and the age of our patient. So first of all, the equipment required, as with any approach to any patient, we have our personal protective equipment. Depending on what is wrong with the patient may vary what equipment we use, and then our padding. Depending, we can use towels, blankets or pillows, whatever's available. So first of all, let's discuss the neutral position. So the neutral position is achieved in adult patients by placing a 2 to 5 centimetre pad below the occiput. In larger kids, often no padding is required, and in newborn infants and small children, padding is placed beneath the shoulders as the occiput is already of a larger size. Now, the two positions we want to discuss are the sniffing position and the ramping position. They both have the same aim, which is to increase visualisation of the vocal cords to assist in intubation. So first of all, the sniffing position is achieved by lifting the patient's head and placing padding below the occiput, with the aim to have the external auditory meatus at the level of the sternum. Now, if the sniffing position has been unable to be achieved, or we have large obese patients or with reduced neck mobility, we can opt for the ramping position. So the ramping position is achieved by placing padding under the shoulders and the head. Again, we are aiming to have our external auditory meatus at the level of the sternum. Now, research suggests there is no improved benefit with either of the positions, so it is best to learn one, learn it well, and apply it to all patients.
Taking a look at this image, we can see 4 positions here: the patient in the neutral position, head elevated position, the sniffing position, and the ramped position. Illustrated on this image or on these images are the oral axis, the pharyngeal axis, and the laryngeal axis. And we can see how these vary depending on the patient's position. With the aim of improving visualization of the vocal cords to improve our success rate at intubation, we can see how the sniffing position and the ramped position does so, therefore increasing our success rate and our grade view.
This next section is going to look at airway assessment and more specifically predictors of difficult airway assessment in the patient that we may be looking to intubate. So first of all, the acronym that we like to apply is LEMON. So look externally, evaluate the 3-3-2 rule, the Mellon-Paddy classification, obstructions and neck mobility. So let's go through step by step. So when we look externally, we are obviously looking at the patient. We're looking for any indicators that might indicate this patient will have a difficult airway. So things like, is the patient obese? Is there jaw abnormalities? Is there a high arch in their palate? Is there a short neck, facial and or neck trauma, loose teeth, prominent teeth, or any false teeth that haven't been placed in? Next, we want to evaluate the 3-3-2 rule. So is the patient able to open their mouth with 3 centimetres? Is there 3 centimetres along the floor of their mouth from the mentum to the hyoid bone? And is there 2 centimetres between the hyoid bone and the thyroid notch? Next is the Mellon-Paddy classification, which measures the degree to which the tongue obstructs the view of the glottis. This is limited to patients that are conscious and that convey commands, as they are required to open their mouth and protrude their tongue. Depending on the textbook and the journal articles, there are some variations in the classification, either 0 through 4 or 1 through 4. Now, I'm going to hopefully insert a picture so you can visualise what I'm talking about when I go through the different classifications. So when we look at the Mellon-Paddy classification, we look at three structures: the soft palate, the uvula, and the pillars. So with class 0, we have the ability to see any part of the epiglottis when the patient is opening their mouth and protruding their tongue. With a class 1, we can see the soft palate, the uvula, and the pillars. Class 2, we can see the soft palate and the pillars, and the uvula is partly visible. With the class 3, we can see the soft palate and the base of the uvula, And class 5, the soft palate is not visible at all, and we can only see the hard palate. If we continue on with our lemon, O stands for obstruction. Is there any tumour, epiglottitis, recent neck surgery, oedema or swelling, or foreign body in the airway? Next is N for neck mobility. Is the patient spinally immobilised and having a cervical collar in place? Is the patient elderly with decreased neck mobility and or arthritis? So when expressing the neck mobility, we're looking for the patient to be able to move their chin forward and down to their chest. Thank you for taking the time to watch this video on patient positioning and airway assessment. I hope it's been informative.